Good evening, everyone. A warm welcome to today's webinar on parasitic infections, best practices in primary care, organized by the Sri Lanka College of Specialist Family Physicians. We are very delighted to have you all with us today. And before we begin, a few quick reminders for a smooth session. Kindly rename yourself to match the name which is required for the participation certificate. You must attend the session for at least 45 minutes and complete the feedback form shared in the chat box at the end. A Google form containing 3 multiple choice questions will be provided. Please select only the correct answers in the check boxes. The correct answers and the participation certificates will be sent to you via email. Please keep your microphones muted throughout the session to minimize disruptions. If you have any questions, kindly type them in the chat box and they will be addressed during the Q&A session at the end. So for today, we have our speaker, Dr. Lalindi de Silva, who's an expert in the field of parasitology. She holds a diploma in medical microbiology and MD in medical parasitology from University of Colombo, and also she obtained her PhD in medical parasitology from Japan. She is currently serving as a senior lecturer in the Department of Parasitology at the Faculty of Medicine, University of Ruhuna, Gaul. So without further delay, I'd like to invite Dr. De Silva to share her knowledge with us. Over to you, madam.
Hello, good evening. Thank you very much for your invitation for me to speak to you all on this platform. So with that, I am a parasitologist. So I want to tell you a little bit about common parasitic infections in Sri Lanka and what you can do about them at your primary care level, because you're a group of family physicians. So let me move on quickly. This is for 1 hour. It's not really an easy task for me to complete everything. So I'm going to grab the highlights of the important diseases. So I'll be covering basically parasites under 3 categories: the protozoans, the helminths, and the arthropods. And under these, I have prioritized the common ones first. And if I have time, I will briefly touch the less common ones at the latter part of this webinar. So moving on to protozoan infections. I thought of doing this as a case-based presentation when I can. So first, let's have a look at this case. It's a 37-year-old Sri Lankan male who returned to Sri Lanka after traveling to Tanzania. And he was febrile on arrival, and he consulted 3 medical practitioners over 5 days after he returned to the country. But at any point, nobody tested him for malaria, right? And his clinical condition quickly deteriorated over these 5 days. And on day 5, he has gone to another general practitioner who has referred him to an ultrasound abdomen, which revealed splenomegaly. So that drove him to MICU of a private hospital in Colombo, and he was already in multiple organ failure. So on physician's request, a malaria microscopy was ordered, and it was only reported early next morning when he got admitted in the evening. And it was diagnosed as Plasmodium falciparum malaria with a very high parasitemia of over 10%. And even before any anti-malarial medication could be administered, the patient died. And this is a very unfortunate death in our country in the post-elimination era of malaria. And the rapid diagnostic test, which we can use concurrently with the microscopy, was available, but it was not performed. If it was performed on admission, maybe some medications could have been administered. And this person has been a frequent business traveler to Africa, but he had never had malaria before. And he has not taken any chemoprophylaxis for malaria on any of these travels to Africa. And at any of these places, he never offered to tell his travel history, right? There are reasons for this, because I'll tell you why. So, why I chose malaria as the first topic is that I think you play the most vital aspect of malaria diagnosis at present, because all these patients, over 90%, present to a general practitioner first. And it's a killer disease. Unfortunately, 2 deaths are reported by now in the post-elimination era, and we are forgetting this disease, right? So most often, since you're the contact, I remind you to ask for the travel history in all fever patients. And this is why I said certain groups are at risk. Those are the returning people from malaria endemic countries, like security personnel returning from United Nations peacekeeping missions, gem traders. Now, going to Africa, these people, most of these people are gem traders, and they sometimes go by illegal means, and they never reveal their travel history unless you probe and ask for it. Right? You should ask in such a way that it's not threatening to them. And then they will reveal that they've been out of the country. So unless they don't reveal. So other businessmen, then pilgrims to like India, people who are coming from India and other people to work as laborers here, then asylum seekers, any tourists traveling from malaria endemic countries, they're all risk groups. And also in pyrexia of unknown origin, you have to suspect malaria. And any patient who has had a history of malaria within the past 3 years, you have to ask them whether they have had, because that is, they can relapse, right? There are long relapsing strains, so they could relapse. Because certain parasite strains like Vivax and Ovale, they have hypnozoites in the liver, and they can relapse at varying intervals. And then people with unexplained anemia, hepatosplenomegaly, transfusion recipients, these are all risk groups. But remember that any person who has had a travel history and now presenting with any of these syndromes, please ask for their travel history and suspect malaria. That is what we ask you to do. So, like I said, because of these hypnozoites, even people who have repeatedly tested negative for malaria again present with malaria, because they can have a reactivation later. And malaria can also present without fever. We have seen many patients, right? And thrombocytopenia, mind you, is a absolutely frequent feature. So in Sri Lanka, most of us just interpret it as dengue in the first instance. And we never think of asking a travel history. If it's thrombocytopenia, it's dengue or it's lepto, but you don't think of malaria. So please think of malaria. If I can get that message across to you all, that is worth everything for this session. Then a little bit about the diagnosis of malaria. We use the microscopic examination of blood smears as the first diagnosis, as the first line still. That's the best. This is a thick smear on the top. You can see that red cells are lysed and parasitemia is very high. Plasmodium falciparum rings, it's full of rings, and this is the thin smear where we look at parasites inside the red cell so that we can help identify the species, because we need the size of the red cell and the presence of the morphology to identify the species. So with that we identify, and concurrently we do this rapid diagnostic test, which is an immunochromatographic test. And in Sri Lanka, we use this pan-malaria parasite LDH and HRP2 antigen mixed combo test. So PLDH, the pan-malaria antigen, is common to all malaria parasites. So all malaria parasites will be detected by that line. And HRP2 is specific to Plasmodium falciparum. So if it's there, that line would also come up. So this is how it is being read. So this is only a control line where it's negative, and this is a positive one, pan-specific, right? That means only this line, the second line is positive, so that means the control and a pan-specific, it could be any species other than Plasmodium falciparum. And then this one is positive for Plasmodium falciparum. This one is a mixed infection with Plasmodium falciparum or any other parasite. Then, of course, the anti-malaria campaign conducts PCR on all patients because now we are in the post-elimination era and we want to characterize all the malaria patients coming in. Right, so in the management, our primary goals now, because we have eliminated malaria, we have zero parasite in the country. There are no parasites. Our mosquito does not carry any parasites. But remember, we have the mosquito. And we have a non-immune population like us who has never been exposed to malaria. So we are very vulnerable, right? We are waiting to get malaria. Therefore, our goals are early treatment of these imported patients who we are having to prevent progression to severe disease and death, and also to prevent the re-establishment of malaria in our country, right? So this is the post-elimination phase of malaria. We eliminated in 2016. So some of the management points I would like to highlight is we have to treat every patient as an inward patient. That's mandatory and under the care of a physician. And laboratory confirmation is mandatory before treatment. There is only one instance where you can treat empirically on clinical suspicion, that is only to save a life, right? And you can see that it was not done for that patient who died in the post-elimination era, right? And the availability of antimalarials is ensured by the anti-malaria campaign. It will be available wherever you want it to be. Usually, brace hospitals onwards, the drugs and the RDTs, everything is available. And if it's not, the anti-malaria campaign will make sure that it's available within 2 hours to anywhere in the country, right? So the management guidelines were recently updated in 2023. So as usual, we are still treating the vivax, ovale, and malariae with chloroquine. Over 3 days, the 223 tablet regime. And the primaquine dosing has changed. Earlier, we gave it for 14 days, but the compliance of this regime was not very, it was difficult. The anti-malaria campaign has to go and follow up these patients, make sure they take it for 14 days. So the dosage has been increased and the duration has been shortened to 7 days. That is a new development in the new guideline. And the chloroquine-resistant patients we treat with artemisinin combination therapy. Right. If it's Plasmodium falciparum and uncomplicated, right? So it has not gone to the severe level. So that there we base the treatment according to the parasite density. That is the new guideline, right? You can refer to it if you're interested, and you can have, it's very nicely detailed. There are a lot of things that I cannot talk about here, but it depends on the parasites per milliliter in your blood, and depending on the density, we will treat with artemisinin combination therapy. That is the first line for falciparum malaria since 2008 in Sri Lanka. So other drugs we are not using. And primaquine single dose we give to eradicate the gametocytes. And if the parasite density is very high, even if it's not severe, we give the artesunate IV, that is the intravenous artemisinin available for Sri Lanka. Now, once it reaches the severe stages, or the complicated malaria due to Plasmodium falciparum mostly, but sometimes it could be rarely due to vivax as well. The first line dose is IV artesunate. It is mandatory to give at least for 1 hour for 1 day intravenous, and then followed by a full course of oral ACT or artemisinin combination therapy. IV dosing could be extended or as long as needed, but mandatorily you have to give at least 24 hours and then followed by a single dose of Primaquine. So the points that I need to highlight to you at primary care is again to suspect malaria, inquire about travel history from all fever patients. Focus on the risk groups that I told you about, right? And refer for diagnosis. Now, remember there are some important things about this disease at this point because our goals are now different. Now, all base hospitals and above, there are public health laboratory technicians who are available for diagnosis of malaria. They are being trained at intervals by the anti-malaria campaign just so that they could, maintain their skills to diagnose malaria. Because a lot of other technicians in all these private laboratories and other places do not have this skill anymore because we are forgetting malaria, and diagnosis of that is not easy on a blood picture for an inexperienced person. So please, if you suspect a patient with malaria, refer them to the nearest base hospital or above hospital, government hospital, where they will test for malaria during daytime, or even if highly suspected, they will come for on-calls during the night. Please don't send malaria microscopy to private laboratories because usually they turn up negative. Even a very, very high parasitemia I have seen being missed in a private laboratory, right? So, and they usually collect these and send to a central laboratory in Colombo or somewhere for diagnosis, and that takes more than 24 hours. And that delay could itself kill the patient. So please please send them to a government hospital. And if the patient is diagnosed and refuses to admit to a government hospital, it's quite okay to admit them to a private hospital. Because once they inform the regional malaria office, they will visit the patient. The anti-malaria campaign will then visit. So that is all right. But don't send samples to private laboratories. And remember, if you have a foreigner, Indian laborer or someone coming to you for treatment, tell them that they have free care in the hospital. They will not be charged any money if they are diagnosed of malaria. They will be provided free care. And the other most important thing is if one of your patients or clients are planning to travel to a malaria endemic country, please direct them to the anti-malaria campaign or the regional malaria office for chemoprophylaxis. This could prevent malaria in all these patients. So the hotline is available. You can search it. It's online. And for Nepal and India, we give chloroquine. And for all other countries, we give mefloquine. So chloroquine, all these drugs, you have to start 1 week prior to travel and then continue until you are in that endemic area, and then come back to Sri Lanka and continue for another 3 weeks before you can stop this. A lot of patients don't like to take it because they think that the side effects, and I think it's your duty to reassure them if they come to you. And tell them that the anti-malaria campaign will provide them with free drugs for up to 1 year even. So they will have their drugs free of charge. Right, so that's about malaria. If you have any questions, I'm willing to answer at the end. And with that, I will move on to another important protozoan in the country, a very, very important one at the moment. So this is a case of a housewife, actually, a female from Tangol, who presented to a general practitioner with a painless nodule on the forearm for 4 weeks. She's a housewife, and she was prescribed some antibiotics because it looked slightly infected, like a abscess erupting. And after 2 weeks, she returns, and the GP notices that the nodule has now ulcerated and it has not healed. So, what do you think this is? Does anyone have an idea?
Leishmaniasis.
Yes, it's cutaneous leishmaniasis. So, it is the vector, interestingly, is a sandfly called Phlebotomus argenticus for Sri Lanka. And you can see comparatively to a mosquito that it's really tiny. So it's like 1/5 of a mosquito. And a lot of people don't even recognize this fly. And people attribute everything, I mean, like Kondurua, Palaturmessa, all these sorts of things, they don't really recognize the sandfly. But they do remember their bites because the bites are very painful, although the sandfly is tiny. So they bite from dusk to dawn, like towards the evening and until during the night and early morning hours. But they rest inside the houses, so the bites are everywhere. And the causative agent is Leishmania donovani so far, but some new research is pointing towards Leishmania tropica as well in Sri Lanka, which is a very recent finding. If you encounter patients, the clinical course of this is like it initially appears like a small papule at the bite site. It evolves slowly over time into nodules, and the nodule slowly ulcerates, and it further ulcerates to become an ulcer. Sometimes there are wet ulcers, there are dry ulcers, and sometimes they get secondarily infected. And they're mainly in the exposed areas of the body. So males, especially who work outside, they may have exposing their upper body without a clothing for the upper body. So they may have on the back, on the chest, and legs everywhere. So some lesions in Sri Lanka also have been noted too. This range here is classical CL, classical cutaneous leishmaniasis. But some of these lesions have evolved into atypical forms, and you can see they're very disfiguring, especially when they occur around face, and a lot of these lesions are actually on the face. And briefly about diagnosis, we can take a smear, split skin smear from the edge of the lesion, or lesion aspirates with a fine needle like an aspirate. And culture and PCR are available at reference centers, although not everywhere in the country, only at few centers. And if you take a smear or a lesion aspirate, this is what you will see. These are intracellular amastigotes with the dot and dash appearance. So they are inside macrophages in the skin. And the management, and as you can see, very specialized management. These drugs are not available in the private sector. We inject intralesionally or intramuscularly sometimes. Sodium stibogluconate or meglumine antimoniate, which are the drugs available in Sri Lanka. And sometimes we give cryotherapy or thermotherapy at 55 degrees. And azoles like ketoconazole have been shown to have some modest activity, but they're not very effective. So at primary care, what I would suggest is that we cannot diagnose or treat this at primary care. This happens in the dermatology clinic of government hospitals. So I ask you to again suspect leishmaniasis, especially now entire country is considered endemic. But there's a higher incidence in these high endemic areas like in the northern Sri Lanka, Jaffna, Anuradhapura. Anuradhapura is a real hot spot. So Polonnaruwa, that area, Vavuniya. And then coming to the southern focus, Tangol, Dikwella, Matara, Hambantota, and Bidipitiya, those are very high-risk areas with the high case burden of cutaneous leishmaniasis. So especially in those areas. And it is usually a non-healing lesion. But remember, the natural history of this is also to spontaneously heal after about 1.5 years. But by then it would have scarred, it would have spread, satellite lesions could be there. So it's better to diagnose early and treat, both for prevention as well as for treatment. So risk groups. Why I said is, yes, there were some defined risk groups in the country, like manual laborers, like people who go to jungles, scrub jungles, certain occupations, and then army soldiers. Those were the risk groups. However, by now, we are seeing it in all sorts of people. Even white-collar job people come with leishmaniasis. So it's spreading everywhere. Now it's ongoing in cities and the villages. So now it's affecting almost everybody. And if you ever come across a situation where you have to advise on treatment, so please, if you see them and suspect, please refer to the nearest dermatology clinic where they will receive treatment. And they can prevent this by wearing long-sleeved clothes, especially during that hours where the vector is active, and avoid any activity outside that time if possible, some repellents, and there is a national strategic plan for leishmaniasis now, but it's still not much is happening regarding the control of this disease. Hopefully it will soon. Right. So moving on to the helminths. Right. So this is a case where a 35-year-old male from Ahangama in the south presented with a 2-week history of unilateral leg swelling. He reported that the condition initially began with an enlarged, painful inguinal lymph node on the same side. Subsequently, he experienced a pain and redness descending along the medial aspect of the limb, which was followed by the development of edema. So this is quite easy to guess. So what do you think it is? Can you tell me the disease and this presentation, what this presentation is, if anyone is interested?
Unilateral leg disease?
Yes, it's lymphedema. Due to
Filariasis, lymphadenopathy.
yes, it is filariasis. What do you think this particular presentation is? Now it has started from the lymph node, and yeah, it's a lymphangitis, which is anterograde or retrograde, because it started from the lymph node and spread.
Retrograde.
Yeah, it's retrograde lymphangitis. So what brings this one about? And this is very classical. If you see this picture of a retrograde lymphangitis, it is like very highly suggestive of lymphatic filariasis. Let me just briefly explain to you why, because filariasis is a very complicated disease, right? It's very hard to explain it within a small period of time, but I thought I would tell you very briefly, because filariasis, we might get infected when we are children, and our chronic manifestations like lymphedema or scrotal edema, hydrocele, it may come 15 to 20 years later, right? Which is now clinically evident filariasis. So that doesn't mean you have the parasite. And sometimes you may have the parasite and still have clinically evident filariasis. That is why I said this disease is pretty complicated, right? So there are two pathological pathways that lead to clinically evident filariasis. One is lymphangiectasia. That means the dilatation of lymphatics. If any patient has adult worms inside their lymphatics and lymph nodes, they will have lymphangiectasia due to the worm products. This is the key preceding lesion of lymphedema, okay, dilatation of lymphatics. Then another pathway is the death of adult worms. Now that case, that is what you saw, acute filarial lymphangitis. These deaths may be natural after they have lived their lifetime, or it may be drug-induced. Sometimes if we treat with DEC, they could have this kind of presentation. Now that is not due to bacterial infection or fungal infection. It is the death of the adult worm at the lymph node, which leads to lymphadenitis due to the worm products. And that infection descends along the lymph tract because now it's descending because the lymphatics are also incompetent. The valves are not competent, right? It's descending. And that will give this picture of descending erythema along the medial border of the thigh. And sometimes it comes all the way down and leads to edema of the lower extremity, right? That may be the first presentation. So for those episodes, these acute filarial lymphangitis episodes, they settle quickly, but people might come to you. Now, if that is the case, that means an adult worm was there, right? Then lymphangiectasia leads to impaired lymphatics, like I said. Dilatation, impairment, valvular function becomes less. So now the function is not so good. That means we are not able to clear the bacteria and other organisms that enter the skin, right? At the slightest entry of bacteria and fungi, we will experience adenolymphangiosis. Now, this is not retrograde. This is anterograde. This will start from the periphery and usually happens in an already edematous limb. At skin abrasions or wounds or entry lesions, bacteria will come, it will settle, it will look exactly like a cellulitis. Okay, so these bacteria and fungi are the key cofactors where this lymphedema will progress. Each time they have a bacterial infection in their limb, lymphedema will become worse, and every time it will go down less. So with time, if you are experiencing frequent acute episodes, your lymphedema is going to get bigger and harder, eventually leading to elephantiasis. So that is how all those beggars in the roads, and they had like massive limbs purely because of unhygienic behavior, right? Okay. So when do you suspect a patient of having in your primary care setting? You can suspect a patient with supportive clinical features if they are living in this endemic belt in the country, right? The entire country is not endemic for filariasis, has not been endemic in the past for filariasis. Now remember, we have eliminated this disease as well, but it's slightly different to malaria elimination. Malaria, we have zero parasite, but filaria, we have reduced it to a level that it has not a public health burden anymore. So remember, there are low levels of infection going on in the country. Transmission is still happening at low levels. So you will see patients, right? So if they are living in this endemic area, then acute filarial lymphangitis, the case I described. Then lymphedema, usually it's unilateral lymphedema. And bilateral, it becomes bilateral with, you have put a question. I will answer the questions at the end, right? So unilateral at first, later becomes usually bilateral. And the adenolymphangiotis, the cellulitis like acute episodes I described due to poor hygiene and wounds and cuts and abrasions, bacterial entry. Then chronic manifestations like chronic lymphedema, elephantiasis hydrocele. And tropical pulmonary eosinophilia is not very common, but if you have a lung symptoms and not responding to your usual asthma medications and having high eosinophilia, high IgE, you can suspect tropical pulmonary eosinophilia due to filariasis. And then monoarthritis with eosinophilia. Sometimes those are occult manifestations. So have a idea in your mind when you can suspect filariasis in your setting. This is the adenolymphangitis picture that I talked to you about. I'm showing this because this is the most important thing at primary care. Patients will come to you with this, right? So you can see the skin peels off and it's like settling. There are blisters, erythema, edema. It looks like cellulitis, and this needs to be managed. So when you're trying to diagnose filariasis at primary care, if you can do a circulating filarial antigen test, that is the filariasis test strip for Wuchereria bancrofti. It's only for Wuchereria bancrofti, and for Brugia malai, it's not available, right? In the private sector, this is quite expensive, like 6,000 rupees something, and it's not quite widely available as well. But this would be the best to detect active infection because this antigen comes from the adult worm. So it will be positive if adult worms are there. So you can see it's active infection. And this can be done at any time during the day. You don't need night. Anyway, the looking for microfilaria would be useless when they are presenting with the clinical features because the worms may be dead a long time back, right? So this would be a useful test if you can do. But we see most often that at primary care, people are doing filarial antibody test. And antibodies, as you know, it only indicates exposure. For filariasis, this is just exposure. So we may all, a lot of us may be having exposure. So this is not very useful to do. So I don't recommend it. And for the management, if you have any evidence or suspicion on the presence of adult worms by this test, by a clinical picture, you can treat the patient with diethylcarbamazine 6 milligrams per kilogram per day for 14 days, right? Like if you suspect acute filarial lymphangitis, you can treat. And if you suspect tropical pulmonary eosinophilia, you need to use the same dose for longer, 21 days, right? But please manage the acute episodes well, and they require antibiotics, sometimes IV antibiotics, please admit them. And they need absolute rest, elevation, and that is usually managed at primary care, and they will keep coming back if they are unhygienic. And the next step is MMDP, or morbidity management and disability prevention. So for this MMDP, they do require long-term management and follow-up to prevent the progression of lymphedema. So please refer them to specialist care. Our Department of Parasitology at Faculty of Medicine, Gaul, is the Filariasis Center. We are the Filariasis Research and Training Center for Sri Lanka. So we have a clinic operating there all 5 days of the week in the morning hours. So you can refer to us. Other than that, there are filariasis clinics along these districts operated under the anti-filariasis campaign or the MOH clinic. Please refer all these patients you suspect of filariasis to anywhere where they will be followed up, because their hygiene and management is extremely important to prevent progression. Right. So soil transmitted helminths, there's nothing much to tell you because they will not directly present to anybody. They are mostly asymptomatic in the community, but sometimes a child might come after passing a worm in stool or vomiting a worm during fever, and sometimes when you screen for the diseases, they may be positive with stool. Sometimes eosinophilic patients are sometimes positive for Trichomoniasis and hookworm disease. So those are the instances where you can encounter such patients. And if you suspect, you can confirm it with a stool examination. Treatment is, of course, you're familiar with. You can treat with a single dose of albendazole or mebendazole. And of course, the prevention is very important. But what I want you to tell you is regular deworming for soil transmitted helminths, like parents want to deworm their children all the time. That is not recommended anymore, right? Because the prevalence of STHs is not so high as it was before. There's a circular if you want to refer, it's online. And once a year deworming in these low risk areas is enough. So for high risk areas, it's twice, like in the central province, Nuwara districts, where there's plantations and tea plantation people are living. So those are high risk categories. Other than that, once a year deworming is more than enough. I thought of telling you a bit about cutaneous larva migrans, because this is, have you encountered this in your primary care? Has anyone encountered cases?
Yes.
Yes, so they come to primary care at first. And this is due to dog and cat hookworms. They can't cause hookworm infection in us, so they do this migrant aberration under the skin. So you will find a history of soil contact. And especially foreigners come with this condition because sunbathing, walking barefoot, especially on the beach. So that history will be very supportive to you for the diagnosis of this condition. And this is a clinical diagnosis. It's not hard to diagnose. You can see these serpiginous tracks, we call snakes, right? So it's mostly in the distal lower limbs, including the dorsum of the foot, starting at an interdigital space. But also you can suspect if you see in the anogenital region, buttocks, hands, knees, because whatever the part, even in the hand, that comes into contact with the soil, the worms will pierce the skin, right? So beaches and that sandy soil is very helpful, conducive for these parasites to develop. So if you walk barefoot, they will pierce your skin and enter. Now, commonly this is secondarily infected because this is intensely pruritic. Patients will scratch and itch and it will get secondarily infected. It will look like impetigo or eczematous. And you will find an active end to this track, like here, right? You can see it's reddish and here it has stopped. That means the worm is there and it will spread until the worm dies. And so it spreads about 1 to 2 centimeters per day until the worm is dead. Natural history would be the worm to die off like within a month. But that is too much time because the patient will itch and scratch and have cellulitis and all sorts of complications. You can try to treat with albendazole. You can give a 400 milligrams per day for 5 days, a 5-day course. And also please prescribe antibiotics if you think it's infected, and antihistamines for the pruritus, and maybe local steroids if there are no open wounds. So please treat holistically. And there is another option where they have tried cauterization of the tract here where the active end is. So trying to kill the worm with a little bit of liquid nitrogen. But that is not really advocated because we are like burning the skin and further causing damage while the surrounding is infected already. So that is not really recommended. So we try with medical management. Okay. Next case, a 9-year-old girl presented with erythema and mild swelling over her left forearm. Initially, a general practitioner diagnosed the condition as an insect bite with an allergic reaction and treated it accordingly. However, the symptoms recurred after a few days with the swelling and erythema migrating along her arm, appearing at different locations. After about 2 weeks, a small lump was palpated over the upper back. An ultrasound scan subsequently revealed the presence of a live worm. What do you think is the diagnosis? Anyone? Have you encountered the migratory or migratory redness in any of your patients?
Lyme's disease.
Sorry?
Lyme disease. Lyme's.
Not Lyme's disease. This is a parasite. And this is quite common in Sri Lanka, actually. You will encounter at some point. Right, if you're not sure, we'll move on. So this is subcutaneous dirofilariasis, right? Caused by Dirofilaria repens. Now the definitive host is dog or cat. This Dirofilariasis causes filariasis in dogs and cats. Subcutaneous filariasis. But in us, it cannot give a picture like that. These are all zoonoses like cutaneous larva migrans. This one also comes into us and causes a different clinical picture, cannot find our lymphatic system, but they will migrate under our skin. Okay, in the subcutaneous tissue. Usually that is where they will migrate, and after a few weeks they will die and get degenerated. But before they die, they cause this all sorts of problems. So migratory swelling or erythema is with the worm when the worm migrates under the skin. Sometimes a lump forms and this lump tends to migrate when the worm is alive. So then usually the worm migrates and then settles at one place after some time, forming a granulomatous nodule at that site. Right? And if this worm, it's spread by mosquitoes, right? If the mosquito bites and the worm enters somewhere in your upper body, let's say face or shoulder, then it will migrate along that track, whatever the track it feels like. And if it comes near your eye, it will migrate across the eye as well. So under the subconjunctiva. Okay, so subconjunctival worm is another presentation. Okay, you can see these kind of erythema with mild swelling like a insect bite, and then localized lumps, okay, which migrate and then settle, and then the eye worm. So if you see the eye worm in Sri Lanka, it's usually Dirofilaria repens. If you see person coming from Africa, then they have another eye parasite there, exactly like this, that's loa, right? If you see an imported case, it's not Diro. It could be loa, right? So for us, this is Dirofilariasis. So at primary care, what you can do is please refer them for ultrasound and diagnosis and surgical referral, because when you do ultrasound, you can visualize the live worm. And if it comes to a nodule and settles, you can do a surgical referral where they will extract the worm. They will do an IND, like small procedure, and extract the worm. And if it's an eye worm, if a patient comes to you with a worm in the eye, refer them on an urgent basis to ophthalmology for extraction, because that is the only place where we will actually catch this worm. Otherwise, it's very difficult, right? Across the eye, we can quickly extract, but they will not be there for long. Please tell the patient to go immediately, right? Because it may be an hour, it may be 2-3 hours. The worm will be gone. right? So the medical management is not very efficient against the Dirofilaria worm. But if it localizes somewhere that is not surgically very accessible or not worth accessing, we can try with medical management. So we try with albendazole 5-day course, and sometimes we combine it with DEC. Ivermectin would be another alternative, but we don't have that drug yet in Sri Lanka. It's not really available, right? And prevention, the vector is Armigerous subulbatus or Manzonia or Aedes. So commonly in Sri Lanka, it's Armigerous subulbatus. That is the mosquito that you see around 5 o'clock in the evening. There you are when you're outside, the massive large black mosquito who comes and attacks you and comes inside the houses. That's the vector. So if you want to prevent Dirofilariasis, one thing you have to prevent these mosquito bites. And the other thing is, if you have pets that you can actually deworm and treat for Dirofilariasis, you can do that as well, because that is where they acquire the larvae and bring them to us. So that is subcutaneous Dirofilariasis. About Enterobiasis, I think you are quite aware about Enterobiasis, and I don't have a lot of information to give you, but you know it's pruritus ani, and children having insomnia, restlessness, worms migrating from anus. If you see it in an adult, please consider their psychological aspect as well, because adults who are affected are very, very upset about this disease. They will not even sometimes talk to you. They are embarrassed, ashamed, and sometimes when they can't cure this, we've encountered very depressed people, because this is a menace, and it's not easy to cure this disease, right? So the principles of management I'll tell you when you're dealing with a patient. If you are very confident that they are positive for enterobiasis, if they say that there are worms coming out, if they show you a video or a photo or whatever, you can treat them. Treat the case, the child or the adult. And then please, at the same time, treat all the family and contacts at home, right? Everybody should be treated on one day. And in 10 days, please repeat the same dosing for the same people. Everyone should be treated again after 10 days from the starting day. That is because there are eggs and larval stages that are not very sensitive to anti-helminthics. So they will mature and again become infective, and you know there's an auto-infective cycle, right? So please treat them again after 10 days, including family. And then tell them about the hand hygiene, about scratching around perianal area and bringing the eggs to their mouth. Tell them how the cycle is happening, how it's transmitted. It's hand to mouth. And tell them that eggs are everywhere, in their clothes, in their bed sheets, so they need to wash them, maintain good hygiene, discard whatever the clothes they are wearing overnight, wash them in the morning, dry them in the hot sun. So tell them a little bit about prevention. And if they still keep coming back to you saying still itching is there, pruritus is there, worms are coming out repeatedly after you do all this, then please refer them for proper diagnosis, which we can do for you. We have scotch tapes, or we can, if they have worms coming out, please request them to bring a sample. Ask them to take one of those worms, put them in a small bottle or something with a bit of water, and bring to us for diagnosis. The best is diagnosis if they are repeatedly telling you the same thing, because sometimes it's not really enterobiasis. Sometimes it becomes psychological, and there have been delusional parasitosis as well, because people attribute little threads of cloth to enterobius worms once they have experienced this itching and distressing condition. Right. What do you think this is? I think I have a little more time. So shall I continue this?
Yes, ma'am.
Yeah, okay. So this case is of a 5-year-old girl from Hambantota who presented with a history of passing motile whitish segments in her stool. Apart from abdominal discomfort, she was otherwise asymptomatic. Despite receiving repeated worm treatment, her symptoms persisted, and she frequently plays outdoors in the garden. This is a sample sent to me by a patient. First, the patient sent this photo via a doctor, and then the sample also reached our laboratory. So, what do you think this is? Anyone has any idea? This is also common, kind of common, especially in the south and I think in Kandy. Do you have any idea what it is? If I say this is the commonest tapeworm infection in Sri Lanka, that is correct. It's the commonest tapeworm. It's okay. Since we don't have much time, I'll move on. It's called Bertiellosis tudori or monkey tapeworm. You will encounter these patients, especially if you're in the south. And this is from the monkey feces, which contaminate the soil in your garden. And there are small, tiny mites in the soil who ingest eggs of this parasite in the monkey feces, and they become the intermediate host. And humans have to ingest that intermediate host, that little mite, in the soil, and we will develop the adult worm in our small intestine. So tapeworms, as you know, they are segmented, and they will pass. The segments keep breaking off while the worm is inside the intestine. These segments, if you remember anything about tapeworms, they have their neurological system, everything in one segment, each segment separately. So even after coming out of the body, they are motile. The neurology systems are working and the segments are motile. Like that gecko's tail, when it gets cut off, it dancing for some time. So like that, these are also dance once they come out of the anus. So it's very distressing to parents to see these motile segments. And if you see this, there is no point in treating these patients for, because children very commonly get it because they play outdoors and then with soil and then put their hands in their mouth or eat contaminated fruit from the ground. So if you see them, if you suspect other soil transmitted helminths and all, of course you can treat with a dose of albendazole, but this worm will not be affected at all by albendazole. So you need to treat them with praziquantel. And that drug is unfortunately not available for us in our country, but we have a stock in our department. So if you see such a patient, please refer the patient to us. We have a treatment protocol where we give lactulose along with this drug because we have to get the entire worm out. As you know, tapeworms are long, and if you leave the head, it will keep growing, right? It's not like other nematodes. If you leave the head end inside the body, it will keep growing segments from that end. So you need to get the entire worm out. So we admit the patient, treat with this drug. So what you can do at primary care is refer them to us. Right, so a little bit about ectoparasites. So that will be the end of my lecture after this. So an 8-month-old infant presented with a generalized pustular rash. On examination, the rash involved the face and scalp. Mother also had an itchy rash over the hands and wrists. The family is from an urban slum area living in a small house. So this is, as you know, it's scabies. It's not hard to diagnose. Intense pruritic lesions in this typical distribution, interdigital spaces, wrist, groin, breast, areola, belt line, umbilicus. So those are in adults. In children, palms and soles may be involved along with face and scalp. And in infants, all lower body may be involved, right? And there will be, this is the mite, Scabies mite, and you will notice thread-like burrows where the mite burrows in the skin, right? But they may not be seen in infants. And this is the other type of scabies. If you heard Norwegian or crusted scabies, looks like psoriasis or like lesion because it's plaquey, scaly, and crusty. And this happens when people who have a suppressed immunity gets this infection. And this is highly infectious because there are millions of mites in these patients, not like in other scabies patients. So if you ever deal with somebody like this, be careful, protect yourself. And for the diagnosis, it's mostly a clinical diagnosis, but you can confirm it with light microscopy if you have skin samples or a dermoscope where you can visualize the burrows. So if you suspect scabies by history, it is an itchy rash and a close contact history with individuals who also had a similar rash. So those are the two important things in the history for diagnosis. Then if you have the typical lesions along with that history, you can treat, that is suspected scabies. And if you see burrows by any chance, it becomes clinical scabies. And if you have any laboratory evidence of mites or eggs or feces, then it becomes confirmed scabies. So the important thing is, whatever these stages of diagnosis, you can treat, right? And you have to treat the patients with 2 applications 1 week apart, because same as enterobiasis, the eggs are there which will not respond very well to treatment. So once they hatch, new mites will come out. So you need to catch those mites too. So give another application after 1 week. And you treat all the contacts living together in that family, right? And you might need antihistamines or topical steroids to reduce the intense pruritus and sometimes secondary infections. And preventing, of course, clothing, everything, bed linen should be washed in hot water at least above 65 degrees of temperature and dried in the hot sun, or in one of those machines where you can have high temperatures. If that is not available, we can seal the clothes for several days until the mites die, completely airtight. And these are the treatments available for us. So permethrin is usually the first line now, right? The 2 topical applications, first 1 week apart, 5% permethrin, massage well into all areas. It can also be applied to face and scalp as well as in children, right? So leave overnight after applying in the evening. Infants and in pregnancy also you can use this. The other drug we have for little children, less than 2 months, where we cannot use permethrin, is sulfur. So 6 to 10% of sulfur you can have from the pharmacies. They will dilute according to the percentage. And you can apply again to face and scalp and in even children less than 2 months old. Then BB cream or benzyl benzoate is also available at present and can be used as a second line, right? It's usually not first line now. Permethrin and permethrin is the best. And oral ivermectin again is important and considered first line where the drug is available. For us, it's still not available. And if you have Norwegian or crusted scabies, it's recommended to combine oral ivermectin with a topical preparation. But we cannot do that, so we will have to go with topical. These are some of the preparations we have at present. And lastly, it's pediculosis. And I thought about telling you just the principles of management. So they lay these eggs at the base of the hair shaft, right? So if you see empty nits, that doesn't mean active infection. If it's more than 1 centimeter away from the base of the hair shaft, it's unlikely to be active or viable, because it means some time has passed. And these eggs hatch in 7 to 10 days, right? So the pediculocytes that we have target the live the larvae, and they don't really kill the eggs very reliably. So again, the eggs will rupture in 7 to 10 days and young larvae will re-emerge. So you need to repeat treatment in that 7 to 10 after 7 to 10 days, right? What we have is permethrin 1% lotion, permethrin 1% cream rinse, which you apply and then rinse off. Then we have this dimethicone spray, and these are two examples of dimethicone spray we have at present. What you have to do is spray this to entire scalp, dry scalp, and massage, leave for 20 minutes and comb it out, and then not shampoo it for 8 hours at least, and then you can wash it off. It's considered very effective, and the mechanism is it suffocates. It's not actually a chemical compound, and it doesn't smell bad, or it doesn't itch or give erythema or anything like permethrin. So it's just a chemical compound that suffocates the mite. It causes respiratory block and asphyxiate the larvae, and they die. So that is one treatment available. So when you're applying pediculocytes, it's important to wash your hair first very well with shampoo and towel dry. Then you can apply these permethrin and whatever lotions, and tell the patients not to use a conditioner, because if you use shampoo and then a conditioner, these permethrin lotions and all will not work effectively. So without conditioner, you have to apply these shampoos and all permethrin based products. Then apply it to damp hair and leave on for at least 10 minutes and rinse. And repeat all this in 7 to 10 days. Right, so I think I will finish with that. Give you any time for questions? Because it's
Madam, there are a few questions. Shall I read them out to you?
right. They're in the chat box, right?
Yes.
I'll briefly go through it. Right. So the first one is, Madam, why don't we do therapeutic excision biopsy of cutaneous leishmaniasis lesions to avoid multiple painful injections? Therapeutic excision biopsy of the entire lesion is not possible. I mean, at first, it's just a small papule, but we don't know if it's leishmaniasis until we test, and we never treat without testing. So I don't think excision biopsy of the entire lesion is possible. And even if you do that, the parasites are known to exist not just at the lesion, it's the edge of the lesion under the dermis. So they will be like forming a halo around the lesion, active edge. So it will be a large excision. I don't think it's possible. So yes, patients do have to commit to multiple painful injections. Right. Madam, if a patient presents with the clinical presentation similar to cellulitis in filariasis with positive antibody test, can we treat with DEC then? That is the issue. Now, if they are coming with cellulitis or in an already edematous limb, it is very unlikely that they are having active parasites, especially if you only have an antibody test. The parasites may have died a long time back. But if you feel that you should treat them with DEC, if you think that if they are young and likely to have acquired this infection like recently, if the edema is like new, fresh, then you can consider that live worms may be present and you can treat. It is very, very case-based, right? Filariasis is very difficult to judge. So if you are in doubt, then I don't think there is any harm of you treating with DEC. It would only give them benefit. So yes, if you feel that it's there, if you feel you should treat, you should go ahead. Worm granuloma, yes, some have answered. Tapeworm, monkey tapeworm, yes, some have answered my question. Bertiellosis tudori. Sorry, what is the pathophysiology of Ascariasis? Okay. Why do people always come and say their children passed bugs? Yes, that happens. Sometimes it is these, sometimes these are the eggs that we swallow in our food. And we have also noticed that some people do present with these children passing like bugs or curuminia, whatever, in their feces. So one thing you can do is to reassure them, and they don't cause really severe illness. Then please advise them on hygiene. It only means that they are swallowing unnecessary things from the ground, right? Please advise them on hand hygiene, food hygiene, and to reassure them, you can treat them with an anti-helminth. Other than that, there is nothing sinister about children passing bugs in stool. Is it okay if I go on with the questions? Do I have time?
Yes, ma'am.
Right, okay. Yeah, I can explain briefly about trichomoniasis if you agree. Is it mandatory to give chemoprophylaxis to all travelers to neighbor India? Yes, usually we give chemoprophylaxis when they travel to India. But all parts of India is not high endemic for malaria. But depending on the region, you can contact the anti-malaria campaign, and if they recommend prophylaxis, please take the prophylaxis. Are we routinely screening our military people coming back from Central Africa for malaria? Yes, definitely. Whenever any group, high-risk group, comes from Africa or India to Sri Lanka, we always find them and screen them. The campaign has collaborations with all these places. United Nations for High Commission for Refugees, then Peacekeeping, all armed forces, and airports, ports authority. So all those places, the anti-malaria campaign has collaborations, and they will have all these patients informed to people informed to AMC and will be screened. But still some are unfortunately missed. What are the effective management strategies we can use to manage severe elephantiasis? Well, best would be to prevent progression to elephantiasis. Like I said, hygiene, washing, and limb care, which is practiced at these filariasis centers, and we do practice it with our patients, and it's very effective because we have to prevent the acute attacks as much as possible. But if it's already developed, one thing you can do is, if there are no ulcers or skin is healthy, you can support it with bandaging during standing hours, right? And you can keep washing them and drying them properly to prevent fungal infections and entry lesions, so that further morbidity will not occur. So elevation, footwear, all those things will come into play. But other than that, while if it has already developed to the severe elephantiasis stage, there is very little we can offer these patients. Mebendazole dose for children and infants. Yes. For infants, we don't give albendazole. So we give albendazole for children over 2 years. Anybody, I mean, above 2 years, you can give 400 milligrams per day for 5 days for CLM. And for less than 2-year-old children, you can give pyrantel palmoate, 10 milligrams per kilogram daily, right? How often should a patient deworm? Deworming is, it depends. If you are referring to the national guidelines, they will tell you the high-risk areas like the central province, you should deworm only twice a year. And in all other districts in the country, deworming once a year is sufficient at the moment, and that is also only for school-going children. There's a circular online, you can search it. And yes, just one moment on Trichomoniasis. Yes, so what I have to actually tell you about Trichomoniasis is not very encouraging, because Trichomoniasis, we can't really diagnose in the primary care setting. You can have a history of this frothy discharge, vaginal, offensive, fishy, smelling fishy, yellowish green or thin discharge with irritation, soreness or burning around the vagina in males, dysuria or irritation. So, but this diagnosis usually involves detecting the Trichomonas trophozoite, which is a bedside test. You have to do a high vaginal swab, take that and immediately put in a saline smear and examine under the microscope, because they are very fastidious and they will die in few minutes. Like before 20 minutes you have to examine, they will die after that, and you will not be able to see the motility or the trophozoite. So usually this happens in the STI clinics in the government sector. It's not even happening in the private sector. So if you have a suspicion and you need to diagnose this condition, please refer them to STD clinics in the government sector, and that should be the ideal way. If you treat, you are treating with either single 2-gram dose of metronidazole, or better if you treat 500 BD for 7 days with metronidazole. But remember that you have to treat all the sexual contacts and also screen for STIs. If you're suspecting this at primary care and just treating with maybe metronidazole and sending off, I don't think you're doing a good job for the community, because you're not really screening for the STIs, or you're still allowing the spread of other STIs in the community. So ideal would be to refer them. But if they are not willing to go to an STI clinic, it's best that you treat them at least with metronidazole. So bacterial vaginosis will come together and all will be treated with metronidazole. So I think that is the best approach you can take. Right. I hope that answers your question.
Madam, one last question. What are the point of care tests used in the primary care setup?
For parasitic diseases, is it?
Yes.
We don't actually have any point of care tests available at primary care. We have the point of care test for malaria, but again, it's not there in the primary setting. It's from base hospitals onwards. Filariasis antigen test is a primary point of care test. Again, it's not widely available, but available at filariasis clinics. Like I said, MOH and anti-filaria campaign clinics, it is available. Other point of care tests we don't really have for parasitic diseases.
All right. Madam, then shall we wind up?
Yes, of course.
Thank you very much, madam, for your valuable time and sharing your knowledge with us today. And also, I want to thank all the participants as well for actively engaging in our webinar today. And the next Zoom session will be on the 31st of January on pediatric poisons. Till then, thank you very much and have a great evening. Good night.
Thank you. Okay, good night.